Very good evening to all of you. Today we are going to discuss how to calculate sample size for common diagnostic research problems. What should you expect at the end of this session? Number one, you will be able to perform sample size calculation for your own study by your own, and number two, you will be able to write a statement in your protocol about how you have calculated sample size. One of the key elements of any diagnostic research is to decide number of participants required to be enrolled in the study. We have to take decision on sample size at the time of developing protocol of the study. But why we need to decide sample size? We design study to draw valid conclusions. We want that results of our study should stand and be precise and add to the scientific evidence. This means our experiment or study should have enough power to detect what is being investigated. Science is about trial and error. We conduct a trial and explore for errors in the trial. Our aim is to keep errors to the minimum. Enrolling enough sample size to keep errors low is required for successful study. This decision has implications for the budget as well as the time required to complete the study. What if we enroll too many patients than required for enough power? It is wastage of resources as well as it is unethical in the sense that it may expose people if we are testing something invasive or harmful. And what if we enroll too few subjects? Then it may not have enough power and our conclusions will not stand. Our study will be inconclusive. Yes, it will also be unethical because you have exposed people to certain risk under your research and that research is now inconclusive. Thus, sample size calculation has to be done at the protocol stage. So, what are the prerequisites for calculation of sample size? Clearly defined research question and hypothesis are necessary for designing any study. Once we have it, we can plan for analysis. Analysis may involve estimation of diagnostic performance parameters like sensitivity, specificity, or it may involve testing of difference in biomarker by using appropriate statistical test. After this, we need to make assumptions about expected results. These assumptions may be based on similar prior research or pilot studies. Sometimes they have to be based on experts' consensus. We also need to specify how precise we want to be about our results and how much of variation in our results is acceptable to us. Now we want to be sure that our estimate with its surrounding interval should include the true estimate most of the times. We need to fix the level of confidence for the same. It is related to type 1 error and conveniently we can fix confidence level at 95% or type 1 error of 5%. Finally, we need to decide how much power we want in our study. Power is probability of not committing type 2 error. Conventionally, we take power as 80%, that is type 2 error of 20%. Don't worry, I will briefly explain what is type 1 and type 2 error later in the presentation. Once these things are ready, we can calculate how much sample size is required to test our assumptions or expectation with a study designed by us, which will have enough confidence and power. Now let us move to applying these learnings to common diagnostic research questions. This slide is created based on the article by Sackett, reference of which is given within the slide. This article is worth reading. It elaborates on common diagnostic research designs from phase 1 to phase 4 Basically, it follows a transition from evaluating a biomarker for feasibility to use as a diagnostic test up till utility of that diagnostic test in patient reported outcomes. We will explore these designs one by one and sample size calculations for same. Let us start with phase 1 questions. We will talk about diagnosis of invasive aspergillosis in critical care settings. We need to diagnose invasive aspergillosis early so that we can save lives or we can decrease the hospital stay. But there are challenges with respect to diagnosis. Number 1, culture is time consuming. Number 2, biopsy. It is difficult to obtain biopsy, particularly in immunocompromised patients or hemodynamically unstable patients. So, availability of less invasive or non-invasive biomarker will solve these challenges. We know that galactomannan antigen detection test is now in place, but let us say this is beginning of designing a study to find galactomannan as biomarker. So, galactomannan is a polysaccharide secreted by cell wall of Aspergillus, and laboratory researchers want to explore if this galactomannan can be used as biomarker. So at this stage, we want to conduct an experiment to evaluate feasibility of a newer biomarker to be used as diagnostic test. So this is a phase 1 questions. So we have to design a study in which we will test serum samples from patients with invasive aspergillosis and patients without invasive aspergillosis or healthy controls. What do we expect from results of such a study? Our expectation is most of the samples from deceased should show presence of biomarker or higher levels of biomarker, and none or very few of the samples from healthy should show presence of biomarker or higher levels of biomarker. If we get results as these, that is, most of the deceased shows presence of the biomarker and most of the non-deceased does not show presence of the biomarker, if we get results as expected, then we can say it is feasible to use this as biomarker for diagnostic purpose. Now, even negative results of such studies, that is, if we do not find any difference in the distribution of biomarker among deceased and not deceased, that is also useful because it saves us from doing further studies with phase 2 to phase 4 questions. After 8 minutes into the presentation, here comes your first sample size calculation. Now, we have to calculate the sample size to detect difference between galactomannan detection among patients with invasive aspergillosis and healthy control. So, we will now make our assumptions. Our first assumption is proportion of the serum sample from the patients with aspergillosis which shows galactomannan presence is 80% because we need it as higher as possible. And let us assume that samples of healthy control also shows presence of galactomannan in approximately 10% because it is biology. Anything can happen. It is not mathematics. So now we have to design a study to detect difference in these two proportions with 95% confidence level, right? And 80% power to detect this difference of 80% and 10%. Now, I will take you to the calculator. As told to you earlier, we are not going to show you sample size formulae and all. We will straight away use already developed web applications for the same. Only thing which we need to take care while using those applications is we need to give due credit by citing these calculators. Provided it will open this page. Now we have to use sample size calculator. I will click on sample size calculator. There are two options. One is you can download a spreadsheet and do calculations in that, or you can use sample size calculator for web. Now it has calculator for many tests. Our test of interest for phase 1 question for our example is we want to detect difference between two proportions, two independent proportions. I will click on that. This will open a calculator for us. Our assumption is healthy people will show 10% of them will show galactomannan presence and 80% of invasive aspergillosis samples will show galactomannan presence. We will assume alpha or type 1 error of 5%, which means confidence of 95%, and we will assume power of 80%, which means type 2 error of 20%. We have to also account for non-response rate or dropout rate from the study and then hit on the calculate button. Nothing will come. What is the problem? Because when we say proportion, it has to be written as 0 to 1. That is 10 has to be written as 0.1 and 80 has to be written as 0.8. Right? Now I will again hit calculate button. It gives us sample size. This sample size is for each group. That is, to detect the difference of 80% and 10%, we will have to study samples of 7 patients each in invasive aspergillosis group and those without invasive aspergillosis group. It is too low. I can do it, right? Why this is so? Because we are dealing with extremes. Our expected effect size or expected difference is huge. It is 70%. So, it is simple analogy. If expected difference is larger, your sample size will be smaller. For example, if we want to check whether tiger and cat are similar or different, how many cats you need to see and how many tigers you need to see? Of course, you need to see only one tiger and you need to see only one cat to say that they are different. So, with the same analogy, if our diagnostic test requires to estimate larger effect, then our sample size requirement will be lesser. Now, let us change these assumptions a bit. Let us say that our sensitivity is or probability of invasive aspergillosis patients who will have galactomannan presence in their serum is, let us decrease it to say 60%, and even healthy controls let us increase it to 20% and see what happens. I will again hit calculate button with other assumptions being same. Your sample size requirement will be high, but still not very high. Why? Because we are dealing with two extremes here. One with disease, confirmed disease, and one without disease or healthy control. In phase 2 research questions, design is essentially the same. You will require patients with confirmed diagnosis who has that disease and you will require healthy controls. Only what is changed is direction of inquiry. From phase 1 research question studies, we have found a feasible biomarker and now we say that those with that biomarker present are test positive and those in whom that biomarker is absent are test negative, and we ask question how many of these test positive also have disease and how many of the test negative also have disease. What essentially we are doing is, again we are trying to determine difference between two independent proportions. So sample size will be calculated in the similar fashion. What if our biomarker of interest was quantitative, that is, it gives results in numbers? Then we have to find out an appropriate cutoff by using receiver operative characteristic curves and area under curve, and if it has discriminatory power or not. And then we label persons as positive and negative based on the cutoff derived from such analysis. And then we explore the difference in the proportion. So these are phase 2 questions, and sample size calculations will be similar. Biomarker under evaluation gives results in numerical terms. For example, level of certain biomarkers in milligram percent or nanogram per deciliter, etc. So if it is in numerical terms, then instead of using test for two independent proportions, we have to use test for two independent mean comparison. So I will calculate here. As expected, we have to have certain prior data either through pilot studies or previously published literature or expectation by experts' consensus. Let us say that difference between the biomarker level is, I am assuming here, as 20 units, mean difference of 20 units, and let us say standard deviation of those two means, pooled standard deviation of those two means is, let us say, 25, right? And type 1 error I have kept as 5%, power as 80%. I will hit calculate. It gives us sample size. So let it be proportion, let it be numerical data. Now you have calculators in your hand, and with prior requirements or prerequisites at your hand and proper assumptions, you can now calculate sample size for phase 1 research question. Now we take our diagnostic research question out of the laboratory. Up till now, we were dealing with two extreme groups, that is those with disease and those without disease, and we were knowing it beforehand that this group is diseased and this group is not diseased. But in clinical settings, there are suspected patients, and we need to administer a test which will discriminate between disease and non-disease. So what we intend to evaluate in such studies is we intend to evaluate diagnostic accuracy, that is sensitivity and specificity of the test, right? So how we will conduct such studies? We will design a cross-sectional experiment in which both, that is index test and reference test, will be administered independently, and those will be assessed blindly. What does that mean? It means that assessor of index test should not know the results of reference test, and assessor of the reference test should not know the results of index test. And then we will calculate these diagnostic accuracy parameters. Prerequisites for such a sample size calculations are explained to you earlier as well. Generic principles were explained to you. So you will need an estimate of the effect. In this case, you will need an approximate idea that how much sensitivity and specificity will be, and how wide or how much clinically acceptable range of sensitivity and specificity you are going to estimate. That decision needs to be taken, and then level of confidence has to be decided, and prevalence of disease is also important. In yesterday's class, you have seen how prevalence changes the diagnostic parameters. Now I will show you sample size calculation for estimating diagnostic accuracy of galactomannan for detecting invasive aspergillosis among critically ill immunocompromised patients. Our assumptions are, we assume that it will be at least 70% sensitive and let us say equally specific. our acceptable width around sensitivity and specificity is 10% of the sensitivity. It should not be more than 20% of the estimate. It will land up into very wide estimate, right? And our confidence interval assumed, level of confidence assumed is 95%. And let us say prevalence of invasive aspergillosis among critically ill patients is 30%. Right. With these assumptions, I will show you how to calculate. This calculation for sensitivity and specificity. We need to impute our assumptions. We have assumed 70% sensitivity, 70% specificity. We have assumed prevalence of 30% and our precision was 7%, which is expressed as 0.07. Our confidence level is 95% and expected non-response rate or dropout rate is 10%. I will just calculate. Here it gives result for calculating sensitivity, sample size required for calculating sensitivity and specificity. For sensitivity estimation you need 549 and for specificity 236. Higher of them is 549. So our final sample size is 549 and with non-response rate it is 610. Wondering what happened and why this sample size is such a large sample size. As told you already, for phase 1 and phase 2 questions we are dealing with extremes and now we are dealing with confusion. So let us change these assumptions and see what happens. Let us say that our sensitivity is 80% and specificity is 80% and with the same prevalence calculate the sample size. It will be reduced. Obviously, if we increase sensitivity further and specificity further, now we are going towards a very good test which have such a high sensitivity and such a high specificity, right? Then your sample size will be further less. What happens if we keep the sensitivity and specificity constant and if we decrease the prevalence? Again I will calculate. Now sample size started increasing. If I decrease the prevalence further to 10%, your estimated sample size keeps on increasing, right? If I decrease prevalence even further to 5%, sample size for diagnostic accuracy study increases. So why we say that diagnostic accuracy studies should be done in clinical settings or settings where we suspect that disease will be present is we basically increase pre-test probability. It will also reduce our burden of sample size. Now let us move to phase 4 research question. These questions deal about utility of diagnostic test. So if we administer diagnostic test to somebody, whether it is going to change the patient reported outcome. So this is the ultimate purpose of our diagnostic test. So one group gets tested and another group doesn't get tested and we see whether there is difference with respect to the patient reported outcomes. Usual kind of study for such a research question is randomized controlled trial, which will take care of many biases. How will we conduct phase 4 research question study? For our example, what we will do is we will administer this rapid galactomannan test periodically to one group of the patients and we will not administer it periodically or not administer at all to other group of patients and we will compare survival, right? So here I have put some assumptions and now you must have guessed it and you are right. What calculator we need to use? Yes, we need to use the same calculator which we have used for phase 1 and phase 2 research questions. That is, we want to identify difference in two proportions, right? So you can try this calculator on your own. Now I will show you a generic sample size statement which you can use in your protocol and manuscript. Do not forget to mention which calculator or which software or which formula you have used. You have to write that. Then you will write that sample size required to estimate whatever you are estimating. It may be sensitivity or difference. Write that. Write your assumptions there. Suppose we were estimating sensitivity. Write that estimated level of sensitivity of 70% and specificity of 80% with 95% confidence interval of whatever the width you have decided. You can write there. And for the difference between two proportions or mean, it is implicit. It is either mean difference or difference in the proportions. And write how much power you have assumed. Usually it is 80%. And that will give the number of samples required. Then add a statement which will adjust your sample size for non-response rate or dropout rate and write final sample size required. So don't forget to cite references because we are using hard work done by somebody and that should be credited. Let us explore few other calculators. Like if somebody wants to estimate agreement in their study by using two different tests, so you can calculate agreement statistics, that is known as kappa coefficient. So if we want to estimate how much sample size is required to estimate kappa, so there are two calculators here. One is hypothesis testing and kappa estimation. So first let us calculate sample size to estimate kappa. So our expected kappa is say 7.7, that is 70% agreement. And how much is the precision? Let us say 0.07, that is 10% of 0.7. And again you have to mention prevalence here. And let us say prevalence is 0.3. Then we will just calculate how much is the sample size required. So you will require sample size of 482 persons and apply both the test, and you can calculate degree of agreement between them, right? So if more is the kappa, that is more is the level of agreement, then, and if we keep this as 0.08, that is 10% of 80%, the sample size calculated will be decreased. Then if you want to test hypothesis regarding kappa, that is whether there is difference in the agreement, then you have a calculator which will be of your use, will be calculation of sample size to estimate correlation coefficient. So I will click on Pearson's correlation here. Again there are two things. One is you can test hypothesis regarding your correlation coefficient, and another is you can calculate sample size to estimate the correlation coefficient. Suppose our correlation coefficient is to be estimated to the magnitude of 70%. Note, correlation coefficient is similar to kappa but for numerical scale variables like level of certain biomarker by method 1 and by method 2, and what is the correlation between those two methods. And again let us say our estimate expected is 10% of 0.7 and rest of the things constant, you will get the calculated sample size. Let's explore calculator for two proportions comparison, that is paired McNamara test. What is the user case for this calculator? You may have to compare sensitivities, that is sensitivity is nothing but proportion, sensitivities of two tests of two different principles. So that is paired proportion comparison. Here we have to use McNamara test. and sample size calculated for Mach number test will be used. So if sensitivity of one test is 70% and you assume that sensitivity of other test is 80%, keeping all other things constant, that is type 1 error of 5% and power of 80%, calculated sample size will be 296. Right? If sensitivity of another test is 60% and one which we are newly designing is 80%, you will require 84 samples. Principle is same. More the difference between two sensitivities, lesser will be the sample size. And this sample size is single group. You have to use both the test on that group, apply reference standard to that group, and then calculate. Right?